Hello, my name is Dr Bobby Sura. I'm Director at Solihull Wellbeing Clinic and founder at Clinical Psychology Direct. You're listening to a live stream interview today. Usually I'm the one that is interviewing people, but today Mobeen Akhtar is going to be joining us. Mobeen is a child and adult psychotherapeutic counsellor. She works with Serenity Psychotherapy here in the Solihull area, and I have an affiliation with Mobeen, and she requested this chat. So I'm going to bring Mobeen in, and we can start. The idea for today really is to talk about what psychologists do. So people like myself, a clinical psychologist by training. Mobeen's just interested to know a little bit about what I do for her own purposes and her own experience. And we thought, why not record it? Because it's a kind of question that a lot of young people, students, people that are perhaps trying to advance on a training path in psychology or counselling, we thought it might be of interest to them. So, Mobeen, hello.
Hello.
Hi there. How are you?
Thank you. How are you?
I'm great, thank you. So I hope you were able to hear that little introduction, Mobeen, and I'm going to hand the reins over to you now. So just carry on, ask what you like.
Thank you. So the first question would be, what is your role and responsibilities?
My roles and responsibilities as a psychologist, and yeah, okay, that's fine. I essentially uh, I manage a team of about 60 people. I sort of support various sort of psychotherapists, counsellors, therapists of all sorts of denominations. We could go into that. So that's part of my role. I have a kind of nowadays a bit more of a leadership and managerial role. But really, the bulk of my work is my own clinical work. So that includes uh, managing referrals that come in to our service here at Solihull Wellbeing Clinic. And it also would mean assessment. So I may well get involved in assessing, meeting with people, or having some initial conversations with them about what's brought them to us, what's their inquiry about, that kind of thing. And then developing some sort of a plan, some sort of an idea of what might be a helpful way forward, and then either delivering that therapy plan program myself, or recommending somebody who could perhaps do that better than me. Try to be humble and work within my limits, So there's sometimes people can do things better than me. They have a particular training or maybe a particular fit that will match better with the client. So that's kind of what I do. I do some court-related work as well, Mobeen. So psychologists are very well placed to work within the court framework. So that might be, for example, things like fitness to plead assessments. If somebody is questioning, the judge wants to know what somebody's capacity is from a mental health point of view. Did they have a sense of what they were doing was wrong? And it might be from more of an intellectual, cognitive capacity point of view. So if somebody has a learning difficulty or a disability, would they understand what has happened here and the consequences? So there could be that kind of stuff. And sometimes my court-related work is also around contacts, residency disputes, looked after care in matters of children. Those parental alienation is another big thing. Although, to be honest, I do a lot less of that work nowadays. It's very, very involved, and it's a little bit heartbreaking as well. So I don't relish the decision making that has to happen in courts. So primarily, my work is one-to-one with clients. I see couples, I see families, I see adults and children, and that's kind of what I do day to day, as well as these sort of interviews and writing articles, that kind of stuff.
And it seems like there's a lot under your umbrella. There's a lot of different things that you do in order to deliver support and to contact with other people. That's very interesting. And hopefully one of the questions will come back to that, so we'll explore that a bit more.
Yeah, sure.
So how long have you worked in this role for? And it seems as though it's been a long time and you've got a lot of experience.
Yeah, so my first job, I was sort of racking my brains about this. I first started in psychology as an assistant psychologist back in 1994, believe it or not. And I qualified with my doctorate in clinical psychology in 1998. So really from 98, that's, if my maths is right, that's what, 25 years, 24, 25 years, something like that. And of that time, I did part NHS work after a period of time and then part private. So from about 2005, I've worked in the private sector, and I went more full time in the private sector from probably 2016, 2015, something like that. So yeah, so fair amount of experience, but it's one of those things, isn't it? The mind is a very complex phenomenon, and trying to kind of become experienced in that, it's really and we're a very young discipline, I feel, psychology, psychotherapy, it's relatively new. So might have a lot of experience, but there's always much more yet that we don't know, as you would guess.
I wonder what would interest you to go to psychology?
Oh, right, yeah. So to be honest, I was at a bit of a loss as to what I wanted to do at secondary school. So if we go back to, I was one of the first cohorts actually to do GCSEs, Mobeen. So our year group was the first to move from O levels and CSEs, which was the old system, to GCSEs. So I'm showing my age there. But as I was studying, doing my A levels, I had science-based A levels, and so I was thinking about medicine. I was thinking about pharmacy, these kind of standard sort of fields that a lot of Asian men and women go into. And I was looking through a careers handbook, and I happened to come across psychology, careers in psychology. And the more I read about it, the more fascinated I was. I'd never studied psychology at that level, at GCSE or A level. I know you can nowadays. But it was really reading that write-up that made me think, this sounds like it's up my street. It sounds a bit like what I'm into and how I view the world and what I'm interested in. And then I just started to go further into it. And my tutors at the college, at the sixth form, they all agreed. They felt it was a very good fit for me. And that was it. And I started to apply for degree courses, and it went from there.
It's interesting that careers find you halfway and just feel like it fits. It's really interesting that you found this connection with you more than the other jobs.
Yeah.
Sounds really interesting. And I do wonder what certain age groups that you work with. I know you said you work with couples and family and adults. So I wondered whether there's children as well, because they fit into a certain age group.
Yeah, so I kind of work with, I'm lifespan trained. So the beauty of clinical psychology is that we, through our training, we work in different sectors, a little bit like medical trainees have foundation doctors, they have rotation. So I've worked with, through the training anyway, with all age groups, and including people, adults and young people with learning disabilities, but also adult mental health, child and adolescent mental health, what we used to call older adults. I don't know whether that's still the phrase that's used, but I had that training across the board. And then my initial work for some years was in a CAMS service, so child and adolescent mental health. So probably I have a very good grounding in working in that field. But really, as I say, from about 17 years ago, I've worked primarily with adults, and so adult mental health difficulties, which we could go into, the sorts of things that I work with. But I also work with couples. I do a fair amount of couple marital therapy, marital or couple therapy. Not all the couples I see are married or necessarily same-sex couples either. And I do quite a bit of work with families too. So I'm dual trained Mobeen as a family and systemic psychotherapist. So which was a further postgraduate training after my doctoral training. That was a 4-year training that I did. And in that period, I worked quite a bit with inpatient populations, so people who had more severe mental health difficulties and were perhaps at some risk to themselves, in terms of their needs. So it's a mix, really. I would say probably 80% of my caseload is adults, individuals coming to see me. Many of them through health insurance, but some of them, they fund the therapy themselves. And probably 15%, I would say, are couples that I'm seeing in one shape or another. And that sort of last 5% is children and family-based work. So that's probably the balance, Mobeen.
How do you carry out assessments of diagnosis with children and young people? When you said you carry out assessments and stuff like that.
Yes. So specifically with children and young people.
Yeah, go ahead.
Yeah, no, I understand. So with all across the board, actually, Mobeen, what I do initially is we often get multiple inquiries every day, as you would imagine, and it's sort of really rocketed through the pandemic, and even though we were only seeing people online during the pandemic, and we've moved back to sort of direct face-to-face sessions now, and for some months, actually, even towards the end of the pandemic. But when people contact the service here, the first thing we do is we have a little email exchange. It's often parents, isn't it, coming through for children and young people. And what we do is we send out a pre-consultation questionnaire. So there's a bit of preliminary email, telephone exchange. Then we send a questionnaire. For parents, they can complete a little bit of background and what we call a psychosocial context. So, the child's developmental history, how their difficulties they're presenting with may have started, how far back, a little bit about the family, their education, schooling, social relationships, friendships, any significant life events that may be affecting them. So obviously we make a lot of those questions optional, because if there is trauma or some really deep-seated difficulties, we don't want anybody to be filling that information out on a form and then feeling emotionally compromised because they've reconnected with lots of difficult feelings. So we ask for a minimum amount of information. If people wish to share a bit more, we're happy for them to do so, but it's not necessary. And then I will have a call, really, either myself or one of my colleagues. It's often myself. I like to sort of have a first interface with people, particularly if I'm going to recommend they work with someone other than myself. I want to have a sense of what's happening. And that's a free 15-minute consultation, Mobeen. So essentially, I'll just pick up on any things that weren't mentioned or I'm curious about in their questionnaire. And then from that point, after that telephone call, we've got a couple of routes. Either I will invite them in to see me face-to-face with the child. So it's often the parent, depending on the age of the child, but usually a parent or carer and the child and young person, could be an adolescent, teenager. I'll see them together in my consulting room space here in Hall Green in Birmingham. And we'll basically go through then what's called an initial assessment. So it's an interview, it's a chat, really. I don't really call it an interview, it is a talk, it's a chat. Just learning about them, trying to engage the young person, which is really important. Because an adult is coming off their own steam, right? And they've come often they've made a decision to be here. But for a child or young person, sometimes somebody else wants them to be here. It might be a parent, carer, school have raised concerns. Maybe it's a problem that the police have raised concerns about. I've been involved in those sort of more forensic situations as well. So. And sometimes it's a solicitor or a court-based process, and they're referred in. So it's trying to engage that in person and see if they would like to be back and come again. And that's the big emphasis. So they'll be talking, learning about them, and then sometimes it's necessary to use what we call psychometric questionnaire, psychometric assessment. So there's quite a few. I like the Beck Youth Inventory. It sort of helps look at things like anxiety, depression, self-esteem, self-concept, anger. So it gives me a little bit of a feeling. It's not foolproof, but it gives you a bit of a sense of what is the severity of this young person's difficulties compared to other young people about that age. So we get a little bit of a kind of a graph as to how where are the areas of particular significant difficulties. So it just complements the interview. I also use something called the ARCADS, which is a child and adolescent sort of inventory that parents can fill out, the young person can fill out. And if it's more specialist assessment, so if it's an assessment of ADHD, that's another process. We need liaison with school. I use the Connors profiles, which are a very good way of getting what we call a 360-degree assessment at Mobeen. So that just means that we can check that the difficulties being presented are pervasive, what we call pervasive across settings and environments, because sometimes if the difficulties are only occurring in one aspect or one dimension of the young person's life, it's unlikely to be what we call a neurodevelopmental condition. It's probably something more emotional or relational or context specific. So Connors checklists, and I like the Achenbach child and adolescent profiles. That's another way of looking at how much is the young person internalizing their difficulties, how much are they externalizing them. So it's a range of things. And if they were coming for an autism assessment, then we use profiles like the ADOS-2 is a gold standard assessment measure. So there are specialist assessments and increasingly specialist assessments, but sometimes, it's just doing a clinical interview, getting to know the person, and we don't need to do all of those things, because what's more important is what the young person has to say about themselves, and the other things complement, really. Does that help?
Yes, that does. It seems though having a background check and going through the developmental and all sorts of those elements of life creates a better picture to have an understanding of the client.
That's it.
So it seems those the assessments that you've just said with ADHD and autism also is flexible. It also gives them a space to say, this might be potential, this, playing a part. So that gives a bit of an idea of how that works and how beneficial that can be for practitioners like ourselves to assess that. But just for ourselves, just get a bit of an idea, and also help clients to get an idea as well for themselves.
Yeah, and sometimes you can screen, do quick screenings. You see, so do we need to have a more advanced or specialist assessment? So sometimes those psychometrics can be a good screening process for that. But as I often say, when it comes to, you may ask me about this later along, Mobeen, but rather than, just focusing on what's wrong with somebody, sometimes, as well as a psychologist particularly, my focus is often on what's happened to them and what meaning does what's happened to them hold, and how is that then affecting them. And then we sort of get into less medicalizing of the person, whether it's an adult or a young person, and more about understanding them. So I often think about, some of the more medicalized assessments. So, for example, psychiatry colleagues are very expert at what they do. They're very important in any sort of mental health setting. But I think, and I hope my psychiatry colleagues won't be offended for me to say this, but I think psychiatrists often sort of are working to bring something to a particular point, a particular kind of diagnostic label, because that then opens them up to thinking about what might be a helpful pharmacological support or intervention if that were warranted. Whereas I think, and I think this isn't exclusive to psychologists, and it's not as though psychiatrists don't do this too. I think good psychiatrists will do this too. Is taking a slightly, rather than moving everything to one point, is thinking about where the point that people have arrived, and then trying to sort of backlight and see, well, how have they got here, and what do we need to maybe look after or pay attention to, and help this young person or adult, for that matter, process to move beyond the point that they've got to, right? So I often talk about preferred futures, so how would the young person or the adult like their life to be? What is their goal? What is their ambition? What's their aspiration? And if we can develop some realistic goals, I'm much more interested in moving towards that space rather than just analyzing what their problem is. Yeah. But in practice, we often need both, because we can't sort of rubbish one or the other. They're sort of two important wings that help the bird to fly, if you see what I mean.
It's interesting you said we try our best not to get lost in this label system. We try our best not to get lost in this idea of boxing everything. And the question we come from is like, where did it start and where is this person now? And what went wrong? And just to create a better understanding of the lifestyle the individual goes through.
Yeah.
I find that it's quite beneficial in my formulation with client work and clinical practice, is that try to understand their script of life and how that would affect them. And that also gives the client a bit of space, replay, do find themselves, discover, rather than getting them to be pushed along the way. That's often quite effective. As a therapist, I always find that as well. So it's really interesting. You said you have to try allowing the client to be held in the right form, rather than them being forced into a little place. It's interesting you said that about psychiatry as well. Sometimes we do, as a mental health professional, kind of end up falling into it. We don't. It's like it's something that we can't help ourselves, but it's something that we acknowledge that actually is much more important than just doing all that. It's just hearing them and to be voiced and heard. It's interesting.
Yeah, and I think it's often repeated. People that are familiar with mental health, there's a lot of prescribed psychotherapies, and evidence base for certain things, but actually for very many decades, and I think it's still true today, that the main agent for change actually is always the therapeutic relationship, what we call the Therapeutic Alliance, And if you don't have that, it doesn't matter how skilled and how many kind of strategies you can offer. They have their place too, So more prescribed therapies like cognitive behavior therapy or cognitive analytical psychotherapy, transactional analysis. There's so many different forms of therapy, but I think we really need to make sure that relationship is there, because it's a trust and what we call the positive regard, the unconditional positive regard, the non-judgmental approach to somebody, seeing them very much as a person and taking that relationship with lots of respect. So it's a collaborative, mutual endeavor. So it's a shared journey of discovery. Of course, we're there to help the client primarily. We're not there to sort of learn lots about ourselves. But to be honest, in the process, as clients learn more about themselves, I think good psychologists, good counsellors, good psychotherapists, they learn about themselves too, particularly through their supervision frameworks. So yeah.
Definitely, I do agree with you. What do you think are the early signs of anxiety and depression in young people and adults that you find play a part?
The early signs of anxiety and depression. Yeah, so, I mean, look, what we know about these conditions, first of all, that they often have a comorbidity. So if somebody is anxious, they tend to be depressed as well, and vice versa. I'm not saying to a high level of clinical need. Sometimes it's more depressive or feeling low. So, and anxiety as well. It's not necessarily chronic or debilitating for everybody, but usually when somebody is anxious, they also have some depressive experiences too, and the other way around. And self-esteem is another really key part of that triangle of comorbidity, things that co-occur. But the early signs, for a child particularly, I guess, it could be things like nightmares, disrupted sleep. If you're noticing a change in appetite, and eating behavior, so that could go either way. Either the child is not eating as they were, or they're over indulging, and particularly sweet and comfort foods, that can be a sign of some sort of distress. If they're losing some of their interest in hobbies, pastimes, activities they used to want to do and engage in. Generally, if they're a bit more disengaged and withdrawn. Of course, as children develop into adolescence, into older teenagers, some of that is a normal process of autonomy seeking and development. But I think what you've got to look at is whether there's a mood change associated too. So if there's more irritability, more frustration, more proneness to anger. Another thing that young people, I think, tend to prioritize if they're not feeling well on an emotional level is that they may start to report more aches, pains, physical symptoms, so it might be that it's a tummy ache, or it's a headache, or the eyes are hurting, or things like that. So those can be very good signs. And in fact, it's not too dissimilar with adults. We're all human beings, aren't we? And it's a human condition. So even as adults, all of those things that are described for children are probably true for adults too. Although adults, in my experience, tend to be able to verbalize better, particularly compared to younger children. So they might be able to reflect on what they're experiencing and have more of a language for it. So they may be able to express it more verbally. So if there's a sense of sadness or a sense of hopelessness or helplessness with their situation, if they're sort of starting to feel that they aren't enjoying life as they once did, if they can't do some of the things they once used to be able to do, so because they're too anxious or they've lost confidence. So there can be a whole range of things. I mean, depression is often misunderstood as somebody's just very, very sad. It can be about sadness, of course, but there's a whole conglomeration of symptoms, behavioral things, cognitive things, what the person's thinking, what's negative thinking, as well as the emotional side. And it's not just sadness, it's often things like anger, irritability, loss of concentration on a cognitive level. So if a child is suddenly starting to present with more difficulties in a classroom and the teachers are calling you in a way they didn't used to, that's usually a sign that something's occupying and preoccupying the young person. So it's a case of knowing your children, young people, as best you can, and being aware of changes, really. And some changes are naturally going to happen as they mature and go through puberty and start to sort of develop interests outside of the home. Of course, with social media now, even the outside home comes into the home. So it's kind of keeping tabs and trying to stay involved with your children and young people, know what's going on in their lives, where are they going, who are they talking to. And if you do that from an early enough age, then you're more likely to notice when things change, and that can be a warning bell. Does that help, Mobeen?
Yes, that does. That goes quite large.
Yeah, good.
Have you engaged with other mental health services, and if so, what ones, and how do you feel it would benefit the client? I know you said you make referrals and assess them and find the right person that you feel would fit them. Just a little bit more. What gives you a feel that they would benefit the client?
Yeah. So I mean, we do necessarily engage with other services. So obviously, sometimes it's GPs at the primary care level. Sometimes it's support services in schools. So the special needs coordinator or the pastoral support team. they would not necessarily contact a service like us directly, but they would usually encourage parents to do so. And then, of course, we may have some liaison there if it feels appropriate. But with adults, I would stay with children for a moment. We may be in touch with what we call CAFCAS, is the sort of essentially children's guardians and within the legal framework. So they are often social work trained and have a good understanding of mental health, emotional well-being also. So there may be liaison at that level. And with adults, obviously with adult mental health teams, community mental health teams, sometimes with crisis teams, we may have involvement on the NHS. We do quite a lot of liaison, I do as well, with Women's Aid, which is, if people don't know about it, it's a wonderful service which is free to use, and it's really for women usually who are experiencing domestic abuse or are in an abusive relationship. So that can be a space that people get support, and sometimes there can be a referral in and liaison on that basis, particularly if the needs require, more specialist support than the counselling they would offer there. And another service we do, unfortunately, have to liaise with, not because they're a bad service, but just because of people have experienced these problems, is a service called RSVP. So that's a rape and sexual violence project. And so sometimes that might be a space that we're liaising. Yeah, I mean, it could be anywhere, but those, I would say, are probably the main places. Now, we obviously have a balance, because the services that clients receive in those services and in here with us are confidential by nature. So the idea that we're all talking about people, when they're not present, that's not really how it is. So it's really at a place where somebody's handing some work over, and it's always with the permission of the clients involved and within their awareness. And it's kept fairly prescribed, so we're not there to sort of talk about everything that's happened in the sessions or everything we're going to do or report back on everything that's happening. It's often just an interface, and they're standalone services. Internally, Mobeen, I'm very fortunate that a lot of people that work in a private setting work very much in isolation as lone workers, whereas at Solihull Wellbeing Clinic and through Clinical Psychology Direct, we've got a very good network of professionals. So whether it's counselling or clinical psychologists, consultant psychiatry, we have occupational therapists, speech and language therapists, we have play therapists, drama therapists, we have, as I was saying earlier, transactional analysis, cognitive analytical psychotherapy, CAT for short, CBT. We have life coaches, career coaches. Trying to think what else really. We have people who are trained in equine psychotherapy, so that's psychotherapy using horses, which it can be brilliant for young people who don't want to engage in a stuffy room like this where I'm sitting. So it's more outdoors and using animals, but they're therapeutic conversations. And we also have something called neurofeedback, which is a big movement in America and is only just picking up traction here. And through neurofeedback, it's a brain training approach that can be very helpful for trauma, ADHD, emotional dysregulation. So what I'm saying is that, in response to your question, that we have that liaison with external agencies. It's not a big part of the work I do. If I was doing that, I wouldn't do much else. There's you could get lost in that. But where the interface is needed, but then internally we do have that. So to develop a good care package, EMDR is another approach that I've not mentioned. So that's a particular approach for trauma. So sometimes we have to develop a package that allows various needs to be taken care of, and not every practitioner, anyone that believes they can do everything, I think is misguided. You do need to use the expertise and training of other people. So I might, for example, see, let's say we have somebody that has a diagnosis or comes in, has an assessment, is diagnosed with an autism spectrum disorder. So then there might be some work done with, in terms of sensory processing needs, for example, or where an OT might become involved, and there may be something around communication, social use of communication, where potentially a speech therapist can be helpful as well, and other areas of specific language problem. And there might be other places where actually it's not talking, but it's a more active, creative approach that's needed, which is where the play and the drama type therapy might come. And rather than it just being standalone, it's nice to kind of have something that we can integrate. Can't do that as well, if I'm really being honest. We can't do that as well in the private sector as they can in an NHS service, but we approximate it and try to work together. Another area is eating disorders, without medical input, without, for example, a psychiatry colleague being able to manage any potential hospitalization, which is scary, I know, but sometimes to save and preserve life. The eating disorder is such a pernicious problem, and the mortality rates for eating disorders are the highest within any mental health population. So it's a very serious undertaking. So having nurse specialists, psychiatrists, psychologists, family therapists is very, very important for this kind of work. So plenty of liaison to do.
It's interesting that we all come into play together and support each other. The client is the main focus, and we're acknowledging that there's so many skills that other practitioners can have, and understanding about these things that will support the client the best way. It's
right.
interesting, and especially with kids, I think with support service that you're saying with LD and like autism, what we find is that it's really helpful to get a bigger picture to understand what's going on, like in schools, what's going on at home, and get the parent informed as well. So I do see the benefits of engaging with other practitioners just to get a full understanding, of course, with agreed a contract with the client. But I can see how others outside the box can also get into, be engaged as well. So the next question. What do you think are the social, political, cultural, and financial motivated trends of diagnosis? It's a very long question, and it's a very interesting one. So I just wondered what your thoughts were and how you felt about that.
So are you talking about the sort of pressures on diagnosis and where those pressures come from?
So if there's social, political, cultural, financial impacts that has on diagnosis.
Okay. Yeah. I mean, naturally, look, when it comes to, first of all, I have to repeat again that the idea of psychological or psychiatric diagnosis, what's wrong with somebody as compared to what's happened to them. I think we have to keep that image, that overview in mind, because we're not, if we only think about it as treating some sort of a disease, so we have classification systems in the UK. In Europe, we tend to use something called ICD-10, which is a kind of international classification of diseases, and in America, but here as well, to some degree, people use the Diagnostic and Statistical Manual, the DSM-5, I think is the latest version. So there are these kind of, frameworks which are used to count symptoms and tally up whether somebody is fitting a particular diagnostic criteria or not. So, social anxiety disorder or some depressive disorder or a personality disorder or an autism spectrum disorder, these post-traumatic stress disorder, so there are these kind of processes. Now, On the positive side, when sometimes a diagnosis can help people get some understanding of the symptoms they're experiencing, and what those symptoms mean, and so that there can be an understanding, and that can be quite empowering, and it can also give them some direction in terms of, okay, well, what do we know helps in this sort of scenario? So that framework, the diagnostic framework, is not something that we should just sort of rubbish and sort of criticize and condemn. It has a very important role to play. Now, what are some of the kind of social, financial, political, cultural pressures on this framework? Well, sometimes you see, to be reimbursed or to be able to access funding through health insurance, some kind of diagnosis can be important. So there's that imperative. Sometimes, if somebody's too unwell to be at work, or there's an employment tribunal going on, or some performance management process, sometimes a diagnostic process can be supportive there. Sometimes, to be fair, what really is important is the person and their experience. So sometimes our social standing, so there are marginalized, populations within society who are less privileged, who have less social support, they have less financial resources. So all of those factors can be really problematic, and sometimes politically, for a government to be able to sort of pool people into this kind of mental health box, whilst that can help create pathways and frameworks and divert funding to support, sometimes it's a diversion as well. I think sometimes actually helping people with their aspects of their daily living, and if they're underprivileged, if they're marginalized, if they're experiencing prejudice, racism, gender based prejudice, if they're living in violence, or they're living in communities where crime and prostitution are rampant, these are actually social and political problems that have an impact on people's mental health and well-being, and they're almost vastly more expensive to solve and more complicated to solve than just to sort of label somebody with stress or post-traumatic stress disorder or something. So sometimes I think we can kind of hide, governments and political organizations can hide behind the mental health diagnosis. And then we can't not have this conversation and mention pharmacological companies, so these very, very wealthy organizations that do create medicines that can be very helpful to people, who are in severe need and acute distress. We couldn't really do without them, I would say. But we have to have our eyes open that these big organizations are also very, very involved in the research, so what research is done, how is that research done, how is it funded, so that they're at the front end of that very often, because good research needs a lot of money. And then they're also involved in the dissemination of the research findings, and that little stereotype of pharmaceutical companies coming into hospital environments and putting on luxurious lunches and promoting their sort of drugs and so on over and above other drugs, So there's a lot of power and influence there that maybe we've got to be aware that clinicians and therapists, psychologists need to have their own wits about them, in terms of what's going on here. And then these pharmaceutical companies and other companies that are invested in a medical model of mental health, which I'm not saying we throw out. There is we need to include that understanding, because sometimes there is an organic neurodevelopmental, neuropsychiatric basis, neurochemical basis to how a person is feeling. But we cannot do that without thinking about their life experience. But these organizations can also be very involved in terms of lobbying the government in terms of programs of intervention, so those pressures are there, and in a way keep diagnoses and diagnostic processes going, because they fuel a whole industry in a way. I don't know what else I could say about it, really, other than just saying that there are a whole network of pressures that impinge upon a person or a family or a community, and can create distress, and if we can try and understand what those pressures and factors are, I think we do a lot better with clients in that modality, rather than just trying to treat a disease or a pathology, because that can be where it can be very empowering and informing of clients. It can also be very stigmatizing and very demoralizing, and can make people feel that they're not normal, and actually we're all normal. We've just got, some people have got more difficulties and challenges than others, so that's the way I look at it anyway. I don't know whether that answered your question, because it's very complicated.
It's a very long question. So you did answer it. It did cover it. I just wanted to come back to the culture, and as South Asian, I think there's a lot of other barriers, and I wanted to ask you, what do you think are the barriers in South Asian adults and young people attending mental health support?
Right, the barriers to particularly people from Asian communities, you mean? Yeah. So, look, I mean, I did quite a bit of research in this during my doctoral training, and I have written various articles that they're available if you were to Google sort of mental health experiences, barriers to help seeking in Asian communities, South Asian communities. So there's a number of issues, really. Saying was that our first gateway is our GP.
Yeah.
Our GPs, sadly, they have great training, expertise, but they just don't have the time, and there aren't enough of them. So a 5-minute conversation with a GP, and when you're struggling to get an appointment, is very, very difficult. So that, I think, we fall at the first hurdle in terms of trying to explain to a GP, or for a GP to understand what we're going through, right? What our concerns are. So that's one of the issues. The second thing is, if you do manage to kind of get your thoughts and worries across to a GP, then they're stuck with, well, where do I send this person? Because, we're talking about diagnosis. It's also used for thresholds in terms of, can a service see somebody? Are you severe enough? Has the problem? So the number of people, for example, anecdotally, who are trying to get a service through CAMS, for example, come back to me and say what they're telling us, and I don't know how true this is, that unless the young person's self-harming or suicidal, they don't meet our threshold. So it's that sort of, where does the GP send somebody? And if you're sending somebody where there's a year's wait or 2 years wait, what does that mean for a 14-year-old or or for an adult for that matter? Their problem is now, and so those can be barriers for all communities, not just South Asians. The South Asian community here is we've got to be careful not to talk about any community as some sort of homogeneous group, because we're all different religions, different cultures. We've been here less or longer than some community groups. There's lots of migrants that have recently moved to the UK, but we may be more or less educated. We may have better or worse English language skills. So there's so many differences, aren't there, in terms of what do we mean by South Asian or Asian communities. In the States, they would really classify Asian as Chinese, whereas in the UK, Chinese would be included in Asian, but we don't necessarily think of Chinese within the Asian group, but they are. So I think one of the things that I found in my research was that when we just talk about language, Mobeen, that there are multiple words for emotional needs within the English language. So you can be depressed, you can be crushed, you can be heartbroken, you can be sad, you can be melancholic, you can be, all of these things. Whereas within languages from other parts of the world, there aren't often as many words. So the language, it's not sort of a language that somebody can explain to somebody. So I came across some research. I think it was a Danish researcher who was researching Krauss. Her name was. She was researching Asian women, and the Asian women were going in to see their primary care professional, their GP, with complaints of heavy chest or headache, persistent sorts of head pain. Now, if the GP refers them to a neurologist or to a cardiologist because they've got a heavy chest or pain in their head that's persistent, sometimes it's missing the point, isn't it? You've got to sort of try and have a conversation with that person about what is their life context. When do these symptoms become worse? Are they better? When did they start? And then you can start to uncover, well, actually this person's in a very difficult marriage, or she's just had a child who's got some health difficulties, or she's just lost her parents, or so when you start to open that up, you can make a more informed decision. And sometimes there's also within Asian communities, again, I don't want to class everybody in one group, so we've got to be careful about that. But historically, if you come from India or Pakistan or Bangladesh or Sri Lanka, doctors are not just doctors. They're gods. They have such a huge status in society that you can't challenge a doctor. You're supposed to be respectful and polite and speak when you're spoken to, and so the idea of being empowered and being a consumer of health services, which is what we are. We pay our taxes. We deserve to be heard and thought about and listened to. If you are from that sort of a heritage and background, you may not feel you can push a GP, or I'm putting a lot on GPs, aren't I, being sadly, but they are the gateway, and I think that's the level we've got to get a lot better. And then the other level is obviously our schools, our schools and colleges. We're only now, there was a government white paper where schools were encouraged, their finances were devolved to schools to pay for counselling, emotional support, that kind of thing. And some schools have been very good at doing that. I have some schools I know, they bring in youth projects, they bring in gang projects, they bring in counsellors, they bring in mindfulness and yoga, and they don't give detentions. They ask someone to come for a mindfulness lunchtime session, and they are really progressing. And sadly, there are still some schools, and unfortunately quite a bit in the private sector, where parents have to find that support for themselves. So if schools could support more and make sure they've got the proper qualified staff and enough of them to be able to service the need, that would be a great help too. But I think it's primarily issues of language. It's also about shame is another factor, that if you are struggling with a mental health difficulty in a South Asian family, again, disclaimer about the homogeneity, but often, in my experience, people with mental health difficulties or learning disabilities are hidden away. They're closeted away. It's considered an embarrassment, or it's shaming, or maybe it's because people feel they'll be judged, that there's some kind of karmic inadequacy. It's because they've been bad people, that bad things happen to them. These sorts of traps that we've created as human beings for ourselves. And then also, and this may be totally foreign to people that perhaps are, white, Caucasian, or very westernized as Asians even. But sometimes the idea of finding marriage partners, so if you've got a daughter who's had a psychotic breakdown and gone into hospital, it's very hard for communities to share that, because they feel they won't be able to find an arranged marriage for their son or their daughter. It will be looked upon negatively, so there are lots, and it's a complex field, lots of factors. I see a number of people who actually can't speak English, and so they tend to be older, first generation migrants to this country, and they require their therapy in Punjabi or Hindi or Urdu. And I can speak a little bit of Urdu, Hindi probably more comfortably, Punjabi much more comfortably. So that helps. So and that takes me on, I suppose, to the next bit, which is having enough personnel and trained practitioners who can, talk in a language that people understand, and have that cultural heritage and appreciation for where people may be coming from. So there's a few thoughts anyway. I'm sure there's more that can be said.
I think it's really interesting you brought up shame.
Yeah.
Shame is the very core ground of towards mental health, and also the education. Not many of them have the education or understanding of what mental health becomes, because it implies all and links into the whole culture understanding and causing stereotypes of what they think it might be.
Yeah.
Barriers stop citations from attending mental health support or receiving that. And if they do receive it, they don't have the language to express to families or friends in their community, saying, what is this for? It's quite difficult, and it's interesting that it comes in place in mental health services. But yeah, it's interesting you brought that up.
Yeah.
So we just got one more question.
Yeah, sure.
What do you think are different? What do you think are the different possibilities contribute to manifest behaviours as relevant to a child psychotherapy? So trauma, abuse, or dissociation.
So, we're being children. If you're focusing particularly on children, we know about things like bullying, whether that's within face-to-face settings, or perhaps it's through cyberbullying nowadays. So any adverse, we call them ACEs, adverse childhood experiences. We want to understand those for adults, but also for children. So we have sort of dimensions of neglect, in terms of children who are neglected. That's a form of abuse, emotionally neglected, physically neglected. We've had some horror stories, haven't we, of children who've starved or been beaten so badly that they've lost their lives, and there's been landmark cases. So that kind of neglect and emotional or physical abuse, which sadly a child is more likely to experience that in their own home with people that they know than with strangers or people from outside of the family. So that's just a sad reflection of the world we live in. On the other end of that spectrum, though, is which you might be surprised at, probably not yourself, Mobeen, because you're a counsellor yourself, but people tuning in that aren't mental health trained may be surprised to hear me say this. But actually, when you are over-involved, so the other end of the spectrum, over-involved, overprotective, there's not enough separation between you and your child. that can really disable and disempower a young person too. So a healthy balance is needed. And then we have something called authoritative and authoritarian parenting. So I'm putting a lot on the parenting in this segment, really. So the idea that what we've got to get right is a balance between emotional warmth, and presence with our children, and enough demands and expectations. And sometimes parents and teachers, and we can get that balance wrong. We're either not warm enough and expect too much, or we're too warm, we don't expect enough. We can create, children who are, essentially indulged or have a very liberal upbringing, and that's not necessarily a great thing. But it's all about finding the right balance within the culture and the setup of any given family or home. And then there are the kind of impacts of, we have a lot of, obviously, it's a world family now, isn't it? And people that are coming here from Afghanistan or Syria or Ukraine, people that have experienced conflict. And only yesterday I was working with a man who is from Lebanon, and he grew up in a civil war, and he was telling me that it was commonplace for him to be on the way to school and hear gunshots and bombs exploding. So those sorts of experiences, can have an impact on us. Yeah, I mean, there's so many, and of course, poverty, lack of resources, feeling marginalized, prejudice, racism, sexism, all of those sorts of things are factors that impact on a child or a young person or an adult. And you're absolutely right. That can lead to. You mentioned dissociation. Can lead to all sorts of difficulties for sure. Dissociation is when we essentially. I talk about it as almost like when a electrical system within a house is overloaded. Well, what happens? A fuse trips and the lights go out, and it's designed to prevent the house burning down, if the cables overheat. And our mind has these breaks, it has these kind of fuse boards in a way, and it will just switch off, so we might dissociate, or we might become very withdrawn. Sometimes people might have more psychotic experiences, start to hear voices, see things, become delusional. We can have aspects of personality can be very severely challenged, so that we develop particular coping responses that help us survive. But when we're not in that traumatic experience, they're maladaptive coping strategies. So if you, for example, learn to become very quiet and withdrawn every time somebody starts to shout within the family, well, then you become very avoidant of conflict as an adult. And, actually sometimes arguments are necessary. Some conflict is important. So, yeah, lots of factors, maybe.
Thank you so much. That was the last question that I had. Thank you for the time to answer them all.
You're welcome. I'm hopeful that that's been useful to Mobeen and to listeners. But thank you for taking that time out to talk with me, and we'll meet again soon, I would imagine. Okay, Mobeen. Thank you very much. Bye bye now.